Members Health event. Delighted to see so many of you here. Our main event today is Dr. Navin Chandra, a consultant and interventional cardiologist. He's going to talk to us about advancements in devices and technologies. I've seen the presentation. It looks very interesting, very informative, and I'm sure you will be both entertained and illuminated by it. We look forward to that. Before that, we will hear from Lance McCarthy, our Chief Executive Officer, who will talk about developments at the Trust and in the NHS. We will then hear from our new lead governor, Charles Fowles. Charles took over from Sarah Pacey on the 1st of November when Sarah's term as a governor came to an end. A huge thank you to Sarah for everything that she did over the last few years. She was very, very supportive. And she was also challenging where she needed to be. She was a really strong advocate for members and for the public who use our services. So a huge thank you to her. And I believe Sarah's on the call today, this evening. Charles will introduce himself to you and talk a little bit about the work of the governors. And Charles will then introduce our keynote speaker as we go into that main event. Those who have been on these calls in the past will recall that the Q&A session sometimes goes well and sometimes is a bit of a technical challenge. So we are piloting a slightly new approach this time. We have asked for questions in advance. So thank you very much to those who have supplied questions, and Dr. Chandra will address those towards the end of his session. There is a dedicated email address if there are any additional questions you wish to ask, either as a result of what you hear this evening or indeed anything you wish to know as members. Please do email us on that email address. We will make sure that every single question does get answered. So it is important that we make sure that you are fully answered in anything you want. If there is time at the end of the hour, we will open up the Q&A as we've done in the past. We may not have time to do that, but as I say, anybody who asks a question will be able to get it answered. And my usual plea, please, just a reminder not to put personal circumstances in any of your questions, as Dr. Chandra won't be able to answer them. I really hope you enjoy the evening. We have an hour, and I think it will be an excellent hour indeed. So with that, I would like to hand over to Lance McCarthy, the Chief Executive. Thank you.
Thank you very much, Brian, and welcome everybody. Thank you all for dialing in. And just up front, just want to say a big thanks to Nav as well for your time tonight and your presentation. So three key areas from myself in terms of things that are happening to the NHS more broadly and to Frimley Health generally that I think will be of use for colleagues to hear. So the first is around industrial action. As you'll be aware, the latest round of resident doctor industrial action is currently still in train, due to finish at 7 o'clock in the morning tomorrow morning. For reassurance, we've had a really amazing, fantastic response from everybody in the hospital, who many clinical colleagues of whom have worked very differently over the last 4.5 days or so, covered different shifts, worked in different ways, etc., to ensure that we continue to support the care and outstanding quality of care to our patients, ensure that we can get the flow of patients into the organisation and discharged home safely and effectively. So a massive thank you to all of those colleagues. For your information, we had about 60% of our resident doctors went out on strike on the first day. On the Friday, that's come down slightly over the course of the last 4 days. We've had a minimal loss in activity, so we've maintained our planned activity at between 95 and 98% of what we would normally have expected to have undertaken over the course of the Friday, Monday, and today. So really great response from that perspective, and we should be back to normal from the morning shift or the early shifts tomorrow with rest of our junior doctors coming back. Second piece I wanted to update on is a range of things around what I'd call the reshaping of the NHS. So as I'm sure you'll be aware through media stories, at least, there's lots of change to the architecture and the way that the NHS works as the government continues to push through a number of changes at pace. Many of our integrated care boards, who are our commissioners of care, are changing. The Frimley Integrated Care Board will be no more from the 1st of April 2026. And it will be devolved into 3 other integrated care boards: a new Thames Valley ICB, a Surrey and Sussex ICB, and a Hampshire and Isle of Wight ICB. And the leadership for those ICBs has been progressed and agreed. In addition to that, there's quite a few changes for us as a NHS acute provider. So there's a specific board assessment framework that we need to complete, which we have done. We've undertaken our self-assessment, and that's currently being reviewed by our regional colleagues. And then that will supplement a new NHS oversight framework, which determines our performance against a range of specific indicators. There's 23 specific indicators for acute providers. Across that, we received our score for Q1, so for Q1 for April, May, and June of this calendar year. We received that in September. We would have been in the best segment, in segment 1. So organisations are put into one of 4 segments, with 1 being the best and 4 being the worst. We would have been in segment 1, but there is something called a financial override for any organisations that are in receipt of deficit support funding, which is about 3/4 of NHS acute providers. So we're in receipt of about £20 million of what's called deficit support funding, which is additional funding over and above the funding we're given to manage care of our patients directly. As a result of that, we've been moved into segment 3, which is the financial override. That means that that prevents us at the moment from being able to put ourselves forward to become a new advanced foundation trust, which is another segment of the government's 10-year plan, which is the ability to become basically a new foundation trust with some additional freedoms that go along with that. So it doesn't in any way reflect the quality of care that we provide. And as you'll be aware, we've recently received some really great CQC reports, particularly for the Wexham site, where it's rated as outstanding, and the Frimley site, where we are rated overall as good. Doesn't reflect that. It reflects a whole range of other issues, including our financial position and our ability to meet some of our access standards and targets. We are close to being able to continue to improve that segmentation. We're waiting for the Q2 results to be published, which will be published alongside the board assessment framework that I was the board assessment which I was just referring to. And once we know that, which is likely to be segment 3 again as well, because we're in receipt of the deficit support funding for the year, we will obviously let you know through relevant newsletters, etc. But as you can see, quite a lot of change happening, both to the architecture, how the commissioning framework is working, how the new providers will be developing into becoming new types of organisations going forward, and then how we will be overseen and regulated and assessed in terms of our overall performance. I'm happy to talk more about that later if that helps. Happy to answer any queries or questions on that. And then finally, the third thing that I wanted to raise was just a reminder to everybody about influenza. So we have seen quite a significant number of cases of flu over the last few weeks. They are high, not just at Frimley Health, but across the NHS generally and in the local population. It's hit early. Flu has hit earlier than it normally does. It normally hits sort of mid-December onwards. It started to hit us a couple of weeks ago. So if you are eligible to receive a free flu jab from your GP, then I advise you strongly to seriously consider please going and having your flu vaccination through your GP, and help protect yourself and protect your family. If you're not eligible, you can still get the flu vaccination, but you need to pay for it through pharmacy. Depending on the pharmacy, it costs about sort of £10 or £15. But we've seen some really quite large numbers, and people really struggling with flu this year, more so than we have in previous years. So I just a plea or a reminder that if either of you've received notification from your GP, or if you are considering it, then please consider seriously about going and having your flu vaccination. Thank you. That was all I'll say, and I'm not sure if I'm handing back to Brian or handing over to Charles, but thank you.
So Charles, thank you, Lance. Charles, go ahead.
All right, thank you. Thank you, Brian. Good evening, everyone. My name's Charles Fowles, and I'm pleased to speak today as the new lead governor of Frimley Health. Firstly, as Sarah's on the call, I want to thank her again for all the work she did previously as lead governor. Really appreciate everything you've done, and it's been very smooth, and a clear handover has been delivered. Thanks, Sarah. I just want to take a few minutes to talk about who the governors are, what we do, and why it matters. So firstly, who we are. We're elected by you, our members, as well as appointed by partner organisations across our local health and care system. We come from many backgrounds, but we share one purpose: to represent the voice of our patients, our staff, and our communities. Our role is not to run the trust. That's the job of the board and the executive team. Instead, governors provide independent oversight and constructive challenge, ensuring that the trust stays focused on delivering safe, high quality, and compassionate care. Some of our key responsibilities include representing your views, raising issues that matter to patients, families, and staff, holding the non-executive directors to account for the performance of the board, working with the trust on our integrated care system partners to support improvements in experience and outcomes across our population, and shaping the future direction of the organisation by approving key appointments such as the chair and influencing long-term strategy. So why does it matter? I mean, Frimley Health serves a diverse and growing community across several boroughs. Your experiences, your ideas, and sometimes your concerns help us champion what matters most. Whether it's the quality of care in our wards, the way we communicate with patients, or how well we work with others across the integrated care system. Your voice helps shape our focus. So how can you be involved? We want to strengthen the partnerships between members and governors. You can support us by sharing feedback with us, taking part in engagement events, encouraging others to become members, or even standing for elections as a governor yourself in the future. Your involvement is what keeps the Foundation Trust model strong and democratic. Thank you for your continued health and for taking the time to be here today. It's a privilege to serve as your lead governor, and I look forward to working with you to ensure that the voice of our community remains at the heart of everything we do. So I'd now like to introduce Dr. Chandra, consultant interventional cardiologist and the Trust clinical lead for cardiology. Dr. Chandra will present on the latest advancements in interventional cardiology, including new devices for structural heart disease and the improved imaging technologies used to diagnose patients, amongst other things. So, Dr. Chandra, now over to you, sir.
Yeah, thank you very much, guys. I hope you can all hear me okay. It's a real honour for me to be able to present at this meeting today to obviously those higher up than me, but more importantly to the members, people from the local community. So I'm very honoured to be asked to speak today. I'm going to be asking Laura, who is kind of behind the scenes, to help manoeuvre the slides a bit for me as we go. So she'll move on to the next slide. Just to start with, we're going to be going through a few things. We're going to be talking about cardiology and what is an interventional cardiologist, what is it that we do on a day-to-day basis, but also where is our speciality heading and what does that mean for an organisation such as Frimley Health NHS Foundation Trust. Now, from the point of view as a cardiologist, what you might wonder to yourself, what does a cardiologist do? And ultimately, we specialise in treating the heart and the cardiovascular system, but our focus is also on disease prevention as well as disease management. Now, the heart, you could argue, is a relatively simple structure. I mean, other colleagues in the hospital often mock cardiology because we are dealing with just one organ on its own. And it is a relatively simple organ here, with the left side of the heart pumping blood around the body, the right side of the heart pumping blood to the lungs, and then a sort of ever running circuit in that way. But it is quite a complex organ, which hopefully you'll be able to demonstrate. Next Next picture again, please. So on the inside, you'll see there's quite a lot going on with the heart. There's 4 chambers. There's 4 different valves that separate the different chambers. There's the heart muscle, which can have abnormalities with it. There's the heart valves that can have abnormalities with them. There's the cords that hold the valves in place. But there's also the electrical conduction system as well. Next picture, please. So you can see from the in yellow there, the electrical conduction system. So again, you can imagine that issues with the conduction system can again lead to things like symptoms, hospital admissions, and comorbidity for any patient. Next picture again. Now, I guess the most important area, in my opinion, certainly, of the heart to deal with is, as an interventional cardiologist, is the coronary arteries. And that's the blood flow that supplies the heart muscle. The coronary arteries and coronary artery disease is an important area of cardiology, and ultimately what interventional cardiologists traditionally specialize in. Next slide. So, from an interventional cardiology perspective, which is what I guess I've been trained to do over the years, my main role really is to diagnose and treat coronary artery disease. But probably my most important role to the trust as a whole is to work as part of an emergency heart attack team and perform a procedure called PPCI, which stands for Primary Percutaneous Coronary Intervention, which is essentially the sort of fancy doctor's way of saying opening up blocked arteries that may have blocked suddenly in the context of a heart attack. But it is important also for me and for patients that myself and colleagues in interventional cardiology in the trust are working within what we call evidence-based medicine to make sure we are using best practice and doing the right thing for patients in a safe way. So it's very important to be aware of all the most up-to-date guidelines, of which there are often updates on a regular basis through a number of learned organizations, but also to participate in evidence-based medicine as well. This can be simply performing audits within your department to try and improve practice. But it can also be a much more larger scale where you might be at the front line of research projects and actually creating new guidelines due to new evidence and new studies that you perform. Next slide, please. Now, coronary artery disease, as I say, the diagnosis really starts with a careful clinical evaluation based on a clinical history and a physical examination, and also involves things like evaluating family history as well. But it's important to also incorporate risk stratification in this as well. And this is important in terms of things like the patient's lifestyle, their smoking status, whether they're overweight, are they exercising really, are they eating healthily, are they managing stress well, and are they sleeping properly? But also other health problems that they may also have, things like blood pressure, cholesterol, and diabetes. But with that risk stratification in mind, we then also look at things like non-invasive ways of evaluating the heart in more detail. Next picture. We often use things like CT scans. You can see an example here of a CT scan showing the coronary arteries. And we can also do other things like stress testing. This used to be traditionally on a treadmill, but now we have a bit more sophisticated ways of doing this, where we make the heart work faster, but look at the heart on scans like ultrasound scans called echocardiograms, or in an MRI setting, where we can see if all the different parts of the heart are moving properly. Next picture. Now, of course, any doctor feels like they're not doing their job unless they're also optimizing medications as well. And, it's not uncommon for when you start to see a cardiologist because you have problems that we've identified, you're often going to be started on appropriate medications to help improve blood flow to the heart, help improve the risk factors that we might encounter to do with your blood pressure or cholesterol. And often you leave an appointment with a few extra medications that you had when you came in. But the other thing that we do as interventional cardiologists from the point of view of coronary artery disease is this concept of PCI and percutaneous coronary intervention. Next slide, please. Next slide. Thank you. Now, as I mentioned, that treating a heart attack is ultimately really what we're employed for. And a heart attack, even now in modern medicine, is still a medical emergency. And this is caused by a sudden blockage of one of the main arteries supplying the heart muscle. If left untreated, it can actually lead to a cardiac arrest. So even now, in Western countries such as ours, it's still associated with quite a significant mortality. And classically, a patient will feel quite unwell. They'll have the classic descriptions of central crushing chest pain. They might feel nauseous or vomit. They may also be very sweaty and clammy, and it can make you more and more with things like a low blood pressure and fast heart rates. And on an ECG, the heart tracing, you will often see characteristic changes called ST elevation that for a paramedic in the community, or if you're in the A&E department, should be a red flag to activate the heart attack team and the heart attack centre. We have one on each of our acute sites in the trust, one at Frimley Park Hospital, one at Wexham Park Hospital, and both of these services are 24/7 that run every day in the year, including bank holidays, Christmas, Easter, all of that. But ultimately, our role is to work as a team, which includes specialist nurses, a cardiac radiographer to use an X-ray machine, a cardiac physiologist to monitor our heart rhythm and our ECG and blood pressure, and obviously the doctors as well, to essentially unblock the artery and restore flow to the heart muscle. Next slide. So here, look, this is an angiogram from a patient from a couple of weeks ago, actually, when I was on call on the weekend at Wexham Park. On the left-hand panel, you'll see an angiogram. You can see in the very top corner a catheter, which is a tube that's come up from the artery at the wrist towards the heart in the chest, and we're injecting dye directly into the coronary artery supplying the left side of the heart. You might be able to notice in the middle of that screen, there's like a stump and a little bit of hold up where the dye kind of holds up, and that's because there is where the heart attack has actually occurred. That's the artery at the back of the heart called the left circumflex artery, and there's no flow going to that area of heart muscle. And this patient, who was relatively young, under 50, was complaining of chest pain, has a background of some important risk factors like diabetes and hypertension, but presented an emergency, so came straight to the cardiac cath lab with the heart in the heart attack centre to be seen and treated by the primary PCI team with myself and my colleagues. So if you look at the right-hand panel, essentially what we've done is we've taken a wire down that artery through the soft clotty blockage, opened it up with a balloon, and then implanted a small stent which measures 3 millimeters by 23 millimeters to hold the artery open and restore blood flow. And actually very quickly, almost immediately, you start to notice improvement. 1, in how the patient feels, 2, in how their blood pressure and heart rate are looking, and 3, also in how their ECG looks. So it's quite gratifying in that sense. You are able to get quite an immediate improvement in how the patient is. Next slide, please. Now, look, the important thing, I guess, about this is if you look at PCI as a whole in the UK, actually total PCI numbers are generally static. Obviously, if you look as far back as the 1990s, where the procedure was still new and growing, the numbers were exponentially increasing to start with. But from sort of around 2010, 2012 onwards, the numbers of total PCI in the UK as a whole, including in emergency and non-emergency settings, has been pretty static at around 90 to 100,000 cases a year. And actually, this is mainly because of improvement in prevention, better medical therapy, but also a number of important clinical trials that have come out in the last few years. Next slide. So I'll just sort of summarize essentially that what these trials essentially had shown was that treating coronary artery disease with PCI in a stable setting actually adds very little additional benefit. And the focus actually should be on urgent and emergency care for heart attacks, an increased focus on risk stratification and disease prevention, and appropriate initiation and optimization of medications to help symptoms of angina. But also involves utilizing non-invasive tests as well first, so things like the stress test that I mentioned, and only really using PCI and stenting if medical therapy fails in the stable chronic setting. Next slide. So for what does this mean, I guess, for interventional cardiology? So obviously, if the numbers of procedures you're doing are relatively stable, it does mean you need to get a bit more scientific about what you're doing. And I think this is very important for patients. So what we do a lot now routinely, and it's very much evidence-based practice, is to incorporate what we call coronary physiology to help us during a PCI procedure. What that means is we can actually put sensors into the arteries and measure blood flow directly to tell us if a narrowing that's present may or may not be significant, and whether there's actually going to be benefit in implanting a stent into that coronary artery. On top of that, we can also do something called intracoronary imaging, which is basically where we put small microcatheters down the artery, which allow us to reconstruct the artery from the inside and put it onto a screen in front of us. So we can size the artery appropriately. We can look at what a narrowing might look like and what it's made up of. Is it kind of stable but hardened and calcified? Is it kind of soft and maybe clotty? And then we can treat that accordingly with stents and then check the effect of our stent to make sure we've done the job that we set out to. And this is very important, I think, for contemporary PCI, that an interventional cardiologist is incorporating these types of important techniques to make sure they're getting the best treatment for you and tailoring the treatment to an individual patient and their individual artery based on the size and what we're seeing inside the artery as well. Next picture. So what does this mean, though? So from an interventional cardiology perspective, I would say what this means is that coronary artery disease treatment is established. We've got appropriate process of how we're going to go about treating it, both in the acute emergency setting, but also in the chronic stable setting, with medical therapy in the first instance, but emergency procedures when they're needed. But what this has really also meant, it's kind of led to this sort of growth of a different type of subfield of interventional cardiology called interventional for structural heart disease. Structural heart disease really means treating heart valve problems, heart muscle problems, or congenital heart defects. But from an interventional cardiology perspective, this is really to do with heart valve disease treatment only. As I mentioned earlier, there's 4 valves in the heart, 2 on the left side, 2 on the right-hand side, the aortic and mitral valve on the left-hand side, and the pulmonary and tricuspid valve on the right-hand side. And these valves can get affected in different ways. The most common is due to age-related degeneration, where the valve gets hardened and calcified and narrowed, and therefore the artery can't, the heart has to work hard to pump through that narrowing. But also the valves can get leaky, where blood essentially is going back the wrong way. When it's meant to be going out of a chamber, it's actually coming back into a chamber, and that can lead to the heart having to work harder to do what it needs to do. Next picture, please. Now, treatment of heart valve disease in particular is well established by surgical treatment, and that is open heart surgery done by a heart surgeon, just something different to an interventional cardiologist. It's well established and it is proven to be beneficial, but it is limited by the fact that it does depend on the individual patient in front of you, and things like their other health issues, how frail they may be, have they got memory issues, and how fit they are in general. And obviously, the more of those things that are favourable, the more likely as the patient would benefit from heart surgery. The less favourable those things might be, the more likely they are to benefit from less invasive procedures to fix their heart valves. Now, open heart surgery, as I say, it is an open heart operation. It does come with a degree of anxiety and fear for a patient as well, and it is associated with a longer recovery time, both in hospital and at home once you've been discharged from the hospital that's done the procedure as well. And that's really where the concept of intervention for structural heart disease has come from, about treating those patients that may not be good candidates for open heart surgery, but would still benefit from having something done to help their valves function properly. Next slide. So if you just go back one briefly just to the aortic valve, I'm going to focus on the aortic valve specifically, just because the aortic valve and narrowing of the aortic valve specifically, and called aortic stenosis, really exemplifies that transition from conventional heart surgery towards minimally invasive keyhole procedures done by interventional cardiologists. So aortic stenosis, as I say, is due to degeneration of the aortic valve due to calcification causing narrowing, which means the heart has to work harder to push through that narrowed valve, and that can then manifest by a patient feeling more and more tired and breathless as the valve gets more narrow. If it's very bad, it can actually lead to things like blackouts and things as well. Next picture. So this is an important public health issue, particularly with regards to severe aortic stenosis. It is the commonest valve disease, which is present in about 1 in 8 people aged over 75. It is traditionally a disease of the elderly, something you see more and more as people get older. And as I mentioned, it's due to degeneration and calcification with time. And actually, when you do get symptoms of breathlessness and fatigue, the prognosis can be quite poor. The data tells us that survival is around 50% at 2 years and 20% at 5 years if left untreated. Now, as I said, surgical treatment with an open heart procedure and a surgical valve replacement is an excellent treatment, but has to be in appropriately selected patients. And actually, around 30 to 50% of people cannot be treated with surgical procedures, and so we have to think of other options for those. Next slide. Now I'm just going to tell you a little bit a story from actually as quite a while ago now, 2002. This patient here is a 57-year-old man who had severe aortic stenosis, but had a lot of other medical issues, including a very weak heart function. Normal heart function should be around 55 to 60%. His was only 12%. He also had other issues, including lung disease, chronic pancreas problems, and problems with his circulation. So actually was not really a suitable candidate to undergo a surgical operation for a new valve to be put in. Now, the doctor standing next to him is a gentleman called Professor Alain Cribier, who is a very famous cardiologist in France, in Rouen, who basically pioneered this technology of something called a TAVI, which is a keyhole procedure where you can try and put a new valve in. And I'll show you a case and some pictures of how that would work. But ultimately, he was able to perform this procedure on the 16th of April 2002, and obviously led to what was quite a fast-paced progression from that date in 2002 to where we are now, where the procedure has been done routinely. Next picture. Next slide, sorry. So just to summarize this slide very quickly, you can see that the first balloon valve procedure was actually done in 1985. That first in-man TAVI procedure on the picture I showed you from 2002. And now in 2017 is when we've kind of got to the stage where you can use it routinely in any patient as long as it's done appropriately and that you don't think the patient would benefit from heart surgery. So quite a short time frame in which there's been quite a lot of progression. Next slide, please. Again, this has been proven also with the studies that have been done, where we started off initially by looking at the most high-risk patients and showing there was a real benefit in doing TAVI compared to either doing nothing or by trying to treat with surgery. And as that has evolved, we've now started to look at intermediate and even low-risk patient populations as well, where we're starting to find that actually the outcomes for both TAVI and surgical AVR are similar, even for lower risk groups. This is quite a kind of game-changing situation for this procedure. Next slide. So at the moment now, as you can imagine, the way this has progressed at such speed, there's a number of commercially available valves. There's sort of divided broadly into two groups: those that can be mounted on a balloon and expanded on a balloon, and those that are crimped down onto a sort of delivery system that expand by themselves. Next slide. Here you can see an example of a balloon expandable valve. You can see the heart in the middle, a wire that's come up from the leg that then crosses the very narrow valve, and the valve is crimped onto a balloon. As you can see in the first heart image, the balloon is then inflated and the valve springs open, and you crush the old valve out of the way. Hence there is no need to open up the chest and take the old original valve out of the way. And then you essentially take your equipment out, leave the new valve behind, which is anchored inside the old narrowed valve to allow the heart to pump more efficiently and start to make the patient feel better. Next picture. So here you see an example of the balloon of the self-expandable valve, similar technique of going up from the artery in the leg with a wire, crossing the narrowed valve, and you essentially unflower the self-expanding valve slowly, so it releases and holds the aortic valve open, but with your new valve in its place, and helps support the aorta. So again, another excellent way of putting a new valve in. Next picture, please. So the important thing to say really from this slide is that if you compare what I said to you about PCI as a whole in the UK from around the era of 2010, 2013, where the numbers were pretty static, you can see here there's kind of a really rapid increase in the uptake of TAVI in the UK as a whole, where in 2013 under 2,000 procedures were being performed per year, and in 2023, 2024, we're nearer to 9,000. So it's really something that's growing, and it's projected to grow a lot going forward as well, because there's a lot of patients out there that are like to benefit from this treatment, and also the guidelines that we have internationally are reflecting that as the way that the practice will evolve. Next slide, please. So you can see from that journey and what we found with the aortic valve that actually there's now a real push to try and do similar types of procedures with minimally invasive techniques without opening up the chest, and ideally going up from small arteries or veins in the leg up to the heart and putting in devices to fix the mitral valve or the tricuspid valve as well. And these are things that are already out and existing, but there's going to be more data that's needed for the similar type of journey to happen. But I'm sure that will come, actually. Next slide. So I'm just going to move on very quickly to a case just to highlight the situation to you. So this is a case, again, quite recently, of an 85-year-old lady that was referred to my clinic with a 3-month history of worsening breathlessness and a corresponding drop in her exercise capacity. Previously been walking unlimited, but dropped down to 100 yards by the time she'd seen me. No other symptoms like chest pain or dizziness to report. Past medical history, really quite common stuff that you might well see in an 85-year-old of hypertension, high cholesterol, previous hip fracture from a fall, and she had a permanent pacemaker in situ as well. Now, her social history is very important. She's actually very sharp mentally. She's independent in her self-care and her activities of daily living. She mobilised with a stick ever since that hip fracture, but she lives alone and can manage well, and is the sort of person we should be looking to treat to do something to help her. Next picture. With any case like this, we have to go through a heart team discussion. It's not up to me as an individual to decide to put a TAVI into somebody. I think this is one of the unique things about TAVI, for example, compared to heart surgery or even PCI, that it has to go through a heart team discussion. And that involves the cardiologist that might be doing the procedure, a heart surgeon, because there'll be some patients that might fall into a grey area. Also having your imaging specialist, that the echo doctors and the CT doctors, and also involving things like the anaesthetic team and your valve clinic coordinators to make sure you, as a group, make the right decision for any individual patient. Next slide, please. So for this lady, after the MDT discussion, we reviewed her echo scan, her ultrasound scan image of the heart. We spoke about her personal circumstances, and we felt that she would be a good candidate for TAVI. So you'll see from the panel on the left-hand side, the procedure is done from the left leg. So what you're actually seeing there is an X-ray video with the hip and the pelvis, and the dye that's going in there is the femoral into the femoral arteries. That's where we're starting our procedure from. On the right-hand panel, you'll see actually the aorta and the aortic valve. We've got a special kind of pigtail type shaped catheter there that's injecting dye onto the valve, and you can see that it's kind of restricted and not moving very well. Just for your interest, the two wires that you see there are her original pacemaker wires that I told you that she had a few years ago. Next picture, please. So on this left-hand panel, now you see that we've got our stiff wire across that narrowed valve, and now we're inflating this valve on a balloon, which is a balloon expandable valve, to kind of push the narrow valve out of the way and leave our new valve behind. And then we take all our equipment out, and you can see on the right-hand panel, the new valve is left inside across the aortic valve and working really well. There's no leakiness going back across there. The valve position is great, and the heart will now start to work a lot more easier to get blood through and out now that narrowing has been taken away. Next picture, please. So look, from the Frimley Health perspective, we've already got expertise and interest and lots of important people that are preparing and addressing, looking after patients with aortic stenosis and working them up for TAVI. We have 3 dedicated clinics across our sites, one at Wexham Park, one at Heatherwood Hospital, and one at Frimley Park. We have dedicated valve specialist nurses. We've got excellent echo expertise across our sites. Both our main acute echo departments are fully accredited with the national bodies and recognised as being excellent centres. We have really good CT expertise. Actually, we have a CT radiologist who used to be trained as a cardiothoracic surgeon. So you can imagine how useful that is for us to be able to call on his expertise as well. We also have, a number of important frailty specialists within elderly care medicine who help us when we're not completely sure about whether we think a patient's going to really benefit from the procedure. So we're not just doing it on people based on their valve and their heart alone. We're also trying to factor in, is this patient going to really get the absolute benefit from this procedure? And we've also got other specialists like vascular surgeons, interventional radiologists within the trust that might be able to help us going forward. We've got TAVI expertise. We've got 2 consultants, one obviously myself and a counterpart on the Frimley Park Hospital site, who perform the procedures at local tertiary centres. I go to Harefield, my colleague goes to Royal Brompton. So we're really developing a smooth pathway and a smooth process for patients to benefit from this procedure. Next slide, please. Now, look, I'm just going to talk briefly for the next 5 minutes or so just about some of the challenges at Wexham Park that we've experienced in a project that we did to kind of highlight this. Look, the population of Slough, which is obviously our largest urban area next to us, is about 160,000, and there is a high proportion of Asian patients of Asian ethnicity in that location, nearly 50% compared to the UK average of less than 10%. In Slough, obviously, we have a proportion of patients who are over 65, but 4% who are over 75. But if you look at our acute medical admissions, those people that present to hospital acutely unwell, actually it's almost 50% of those are also of Asian ethnicity. Next slide. So we know that from the UK sort of registry data that the prevalence of aortic stenosis is around 1.5% when you're over 55. It rises with age to 3.5%. But the sort of UK TAVI registry data, which we have to submit all our data to for TAVI procedure, shows that only 3% of TAVIs are being performed in Asian patients. But for some reason, we don't really know exactly why, ethnicity is poorly recorded. And what we're finding, certainly in our own environment, the proportion of patients that we're seeing in the outpatient and inpatient setting in cardiology who are of Asian ethnicity is high, as we'd probably expect. But if you look specifically at the specialist valve clinics, the proportion is actually quite low. So we wanted to do a project to kind of understand what the reality was with that in terms of numbers and why this might be happening. Next slide, sorry. So the aim of our study was to first of all evaluate the proportion of patients of Asian ethnicity seen in the aortic valve clinic and try and understand if this discrepancy was real and why it might be, and then to try and propose some strategies to overcome what might be a ethnicity-based health inequity to try and manage patients with aortic stenosis better. Next slide. So we looked over a 3-year period. We basically looked at the number of patients consecutively coming into the aortic valve clinic and compared that with the general cardiology clinic as well to look at what the difference in numbers was. We then embarked on what we called a patient engagement plan, where we worked together with the South London Cardiovascular Networks because of their similar experience with patients of Afro-Caribbean and Black ethnicity. We then interviewed patients of Asian ethnicity to understand what they felt the deficits were and what we were providing in terms of care for them and access for them. And then we tried to create a forward plan of what we were trying to do about it. So I'll go through some of those for you next slide, please. So in essence, the results showed quite a big difference. It showed that in the aortic valve clinic, under 4% of the people we were seeing were of Asian ethnicity. But in the general cardiology clinic, it was over 40%. So nearly a sort of 10, 11-fold difference there. Next slide, please. We then did an interview with different patients that have had aortic stenosis that went on to have treatment for it. We asked them a number of questions. We interviewed them, and obviously with consent, and then we presented this data to try and understand what our areas of improvement could be and kind of find out from them what the challenges they felt were important. Next slide, please.
So she's saying that first you can't.
I think you can. We'll skip over that because it's difficult to hear. So what we found from that exercise of the interviews and with the patient engagement plan, there were a number of factors that were making things difficult. That includes patient factors, healthcare factors, and population factors that vary from things like language barriers, comorbidities, perceived frailty from an individual patient, but also to a degree a lack of trust in healthcare, lack of engagement in healthcare, perhaps later presentation to acute services. But also things like lower socioeconomic status within our main urban area of Slough, the concept of multi-generational living, which is more prevalent in that area as well. And again, a sort of unawareness of the impact of heart valve disease specifically, and the fact that there are options to treat it, certainly beyond open heart surgery. Next slide. So what that study showed, that there was evidence of healthcare inequity based on ethnicity, but it is not as straightforward as that. There is a complex interplay between social deprivation, and we know that over 70% of people in our local population fall below the national average, with issues to do with things like higher household size, overcrowding, vulnerability in adults and children, and a higher incidence of crime. But also, actually, if you look at ethnic groups as a whole, even if you looked at the population of Asian people in India, aortic stenosis is actually less prevalent than other valve problems. Actually, mitral valve is more of an issue there. So you could argue that we're actually looking in the wrong valve problem in any case. But also in the way that Asian people have migrated to this country, you have the first generation immigrants, people like my mum and dad, for example, who are now in their 80s, who are older, and people of that generation have already passed away. And then you've got the second generation, which is people like me who are in your 40s. So actually there's a gap of about 30 years in there where you could argue that we haven't actually manifested the problem of aortic stenosis yet. So it's something that a wave that may be yet to come. Next slide, please. So we then went on a number of steps. We presented our study at an international conference called London Valves. That was last November. We then joined, next picture please, we then joined forces with the South London Cardiovascular Network, as I mentioned, to try and gain experience from their work with the Black, African and Caribbean communities as well, where there's a similar issue of perceived health inequity. We then also worked together with the Valve for Life charity to try and work on ways in which to increase access for these sort of more non-invasive keyhole type therapies to help treat valve disease. And we organised something called next picture, a Your Heart Matters event, which was essentially a community-based project in the car park in Slough in Asda, which was attended by our local MP as well, who came and helped us raise awareness. And we actually managed to screen between 250 to 300 people for potential heart valve disease. And again, we were quite pleased that we had a very high proportion of, firstly, patients of Asian ethnicity, but also of women as well, who are across the board nationally underrepresented in terms of diagnosing and then managing heart valve disease. Next slide. So look, thank you very much for your time. This is our wider team there on the day that our local MP, Mr. Tandesi, came to visit and hear about our work. You've got a team there of, you can see, a few consultant cardiologists, a few junior doctors, but also lots of specialist nurses, our operations and management team, and also had some volunteers to help with translation and help to engage with our community groups. We've still got further projects in mind of where we're going next with this, but that is essentially where the direction of travel for interventional cardiology is going. And I guess I would summarize by saying, we do offer a lot of services, and we'll certainly be able to treat people in the emergency and acute setting. We are using our evidence-based practice to make sure we're treating people appropriately for those with a kind of more chronic or stable situation. We are looking to engage with the latest technologies and techniques, by being able to perform more complex procedures at our local tertiary centres for things like TAVI and aortic valve disease. But we are, having to really stick to our thought process is of, yes, we have to think about what we can fix, but we also have to think about how should we fix it and how do we do it safely and properly for our patients in our community. Thank you very much for your time. Should we move on to some questions?
That was brilliant. Thank you very much, Dr. Chandra. Really interesting. And I think when people go back and have a look at the recordings, some of the information on those slides are really interesting. So we have had a number of questions in advance.
Yeah.
They are, as if by magic, appearing on the screen so that you're able to see the questions that have been asked. So I think Navi, if I leave it to you to go through and answer as you see fit. Thank you.
Yeah, absolutely. No, thank you very much, people, for sending your questions through in advance. It makes it a lot easier for us to go through things, but I'll go through them in order. So the neocord is a keyhole way of treating a mitral valve problem, mainly to do with the leaky mitral valve. So it is minimally invasive, and it is a very useful way of treating that problem, but it is only for appropriately selected patients. It's not for everybody that has a mitral valve problem. And this applies to all types of heart valve disease, actually, is that there are lots of different ways of doing things, but our job is to work with the patients to understand what is the right thing to do for an individual. For some people, the traditional open heart operation is absolutely the right thing to do. For some people, actually, doing nothing and just giving tablets is also the right thing to do. But for some people, yes, exploring the sort of more novel and newer technology is definitely also the right thing to do as well. And we should act as the bridge to the sort of tertiary centres for those patients that need that type of treatment also. So mitral valve repair with neocord is not something we do at Frimley Health. We won't be doing it anytime soon. It's very much a cardiothoracic-based procedure. But that procedure and that type of procedure, I'm sure, will be becoming more and more common, and something that I think we'll be seeing more frequently going forward. Okay, so question number 2 about coronary artery status and follow-up after stent placement. So this is very important. Now, if you have a stent put in because of a narrowed or blocked coronary artery, we wouldn't routinely go back in and check that stent again and again invasively with an angiogram, unless there is some signs of symptoms in the first instance, number 1. Number 2, unless we've tried and not been able to improve things with tablets. And number 3, if we found evidence of there being a problem with the blood flow. So those are the important ways of thinking about it: symptoms, medical therapy, and evidence that there's a problem with blood flow. Okay. The reason that we don't go straight to an invasive procedure with an angiogram again is because it is an invasive procedure. It does come with an element of risk, and exposing somebody to risk without there being a reason to is not the way we like to practice, and certainly not what we call evidence-based practice. We want to do things in a safe, structured way to begin with, unless it's an emergency situation, in which case, of course, we go in and do what needs to be done quickly and do the angiogram. So the way to guide us is to mainly be guided by symptoms, optimize medical treatment with tablets, and then look for evidence of there being a problem with less invasive tests like scans in the first instance. Okay. Now, the question here about aortic stenosis and TAVI. So look, this is again a very good question, actually. As I say, the utilization of TAVI across the country is going up fast, and it's going to continue to increase. There are more and more people being identified with aortic stenosis. The evidence from all the research trials suggests that actually that you can do this safely in lower and lower risk groups of patients as well. So TAVI is going to continue to grow. I wouldn't say that it's going to replace aortic valve surgery completely, because there are, as I mentioned, a proportion of patients that should have aortic valve surgery is going to last them and be appropriate for them specifically. So it's not going to replace it, but it's going to be something that's more and more frequent going forward for patients. You will often find that people that have a severely narrowed valve also happen to have coronary artery disease. You wouldn't specifically treat the coronary artery disease unless it also came with symptoms like chest pain and signs of angina. If that was the case, you would probably treat the coronary artery disease first with stents and then go ahead to do the TAVI. You would usually do them all in one go because that's quite a lot to put a patient through. But it does depend on an individual basis. If somebody has severe coronary artery disease, that is going to be very challenging and difficult to fix. We may not explore that option further and might start thinking about appropriate management just with medications instead. But it is always about patient selection for any of these things that's invasive. You've really got to think about the patient first and work with them and their family and relatives about what we think is the right decision. And as I mentioned about the heart team MDT, you cannot put a TAVI in any patient in this country without it going through a multidisciplinary team meeting first, which I think is a real strength. I think that's a very important thing about how TAVI is done in this country, actually, and that heart team dictates everything. So it's a group decision rather than one person potentially abusing or underestimating the value of that system. Okay, so CT scans. Now, CT scans are very important, as I mentioned, as a non-invasive way of evaluating the coronary arteries, and we also use it in TAVI, as I showed you. So, it's mentioned about the communication that goes with the fact sheet for CT scans, and it might take up to a few weeks. Look, it can be done. CT scans can be reported on the same day. Certainly for inpatients who've had a scan done on the same day, we usually get a report within the same day, often within less than a few hours, actually. For outpatients, the reporting mechanism can often take longer. We recommend up to 4 weeks for that, but those results are done sooner than that. This is a question, I suppose, mainly for radiology, but it unfortunately is done for a reason, because of the fact that, like the majority of services in our hospital and any hospital up and down the country, they are overburdened. So just trying to get through your outpatient waiting list can take a bit of time. There is an important issue to do with quality assurance, checking and double checking things as well, and all that adds a bit of lead time into the report coming out. So I'm sure that time will improve as things go forward, but we do have those challenges to deal with, unfortunately. Okay, so non-invasive treatments for narrowed arteries. So yeah, look, this is really important. Obviously, there's bypass surgery, there's stenting, as I mentioned, but as I said earlier on, for stable patients in particular with chronic angina, there is an increasing focus on managing this with medications first and foremost. Now, as well as that, there is a real focus on disease prevention, and this is really making sure we target patients or people before they become patients to understand about heart disease risk and things like obesity, things like habits that are not good for you, like smoking and lack of exercise. And if you go on things like the British Heart Foundation website, this is really what is on the first things that you see on their websites. It's about prevention. It is about making sure we're not in a position where you need PCI or bypass surgery. So that's the first thing to say, that the focus should really be on that. In fairness, actually, I think primary care are actually quite good at, when your risk goes up because of age, they may often invite people in to come and have blood pressure checks and cholesterol checks. My own GP did that to me when I turned 40. They asked me to come in for those checks just to see where I stood in that risk profile. So I thought, that was quite a good proactive way of doing things. There isn't a drug as such that's going to make narrowed arteries go, disappear, but they can certainly do what we call plaque stabilization, where you can minimize the chance of it getting worse. And in some of those people, it will make it get better, but you just can't necessarily predict that. You have to sort of do it on a case-by-case basis of each individual. Okay, so the next question, number 6, is about something called an ablation. Now, an ablation procedure is a very different type of cardiologist. I sort of mentioned earlier on in the talk about all the different components of the heart and how complex the structure is. And the reason for that is that, the heart rhythm and the electrical system of the heart is dealt with specifically for procedures by a different type of cardiologist, something called a cardiac electrophysiologist. We have 3 of those across the trust that basically will look at ways of controlling heart rhythm disturbances. And one way of doing that, which is a procedural way doing it is something called an ablation, where you go up from the vein in the leg into the right side of the heart. You try and find where the abnormal electrically active areas are coming from and essentially zap them away with radio frequency waves. So it's a really good procedure. Again, for an appropriate patient. It's not for everybody. It's only really for those that are struggling with lots of symptoms and for whom medical therapy is not fully working in the way you want it to. But it is quite a safe procedure. Like anything invasive, does come with some risks. The risks are low, at less than 1% for any serious complications. But it does involve putting tubes into the blood vessels. There is a bleeding risk associated with it. So you may often require to stop any blood thinning medications if you're on those before you do a procedure like this, similar to what you do if you're doing an angiogram or a TAVI. Because we're putting tubes into the arteries, we don't want to increase the risk of bleeding. So we usually stop blood thinning medications for a few days before the procedure and a few days after the procedure as well. Okay, now, time to follow up for stent procedures. Now, in my opinion, best practice should be that if you've had a stent procedure done, and I'd like to think that it's been done in the appropriate order of events of evaluation of symptoms, risk profile review, medical treatment, and then non-invasive testing. And if you've had a stent done after all of that, I think you should be seen by your cardiologist that did that procedure to check that you're okay and that the desired effect has been achieved. Okay. Now, what I would say is that beyond that first appointment, it should be in the remits of the general practitioner in primary care to manage things thereafter. So things like risk factor modification, checking blood pressure, checking cholesterol levels, checking rates of diabetes. That would be their remit, and they can obviously refer back to cardiology if there's a need. I would also say that there is an important emphasis and focus for the patient as well, that if you've had a stent procedure, you've also got to do your bit of looking at what you can improve upon in your lifestyle in terms of diet, exercise levels, smoking habits, exercise amounts, so you can look at what you can also do to help the situation, also things like making sure you're taking your medications. So it's sort of several layers to this sort of issue of follow-up and review afterwards. But in my opinion, you should be seen at least once by the cardiologist that did the procedure after a stent's gone in to make sure. Okay, if that hasn't happened, we should be getting on top of that. But we do a lot of these procedures every year, so the time it takes for that can be a bit slow at times. Unfortunately, again, that's due to the pressures in the system, but we will certainly aim to achieve that. Good. Any questions from anybody else or comments?
Dr. Chandra, thank you so much. I think we're nearly at our time. Gosh, you've given us 45 minutes of there's a lot of information there. Really interesting. No, please. It was, we were all listening. You had our absolute close attention. So thank you so much for that. Can I just say to everybody on the call, if you do have further questions, please do use the email address that came with the event. We will make sure that all questions are answered, and Dr. Chandra has been very generous with his time and has offered to look at every question that is sent in on the back of the health event. So thank you so much for that. Can I also ask everybody you will get some feedback forms. Obviously, we've tried a new way of doing the Q&A this time. We'd be really interested in your feedback. What worked? What didn't work? What would you like to see differently? What would you like to see more of? Usual kind of things. So please do engage with us on that. These are events that are designed for you and around your needs. So please let us know what they are. So on that, I think we're at the end of our time. Thank you again to Dr. Chandra. Thank you again to everybody else who spoke, and for those from our communications and engagement team who put the event on. And I will wish you all a good evening. Thank you very much. Good night.